Next speaker is Dr. Ralph Eagle, who is from Wilshire Hospital, Philadelphia. He'll be speaking to us on histopathology of retinoblastoma governing management in 2022. Discussant is Dr. Kaustubh Mule from Center for Zaid Hyderabad. Ralph, you can share your screen.
Pardon me here. Okay, can you hear me?
Yes, Ralph.
Okay, Santos, thanks for allowing me to participate in this excellent symposium. We're going to talk about histopathology. Actually, we're not doing as much histopathology thanks to all your successful ice-sparing therapies. I have no financial relationships to disclose. Diagnosis, again, here's a few interesting cases that we diagnosed with histopathology. This is a 11-year-old girl from Hawaii who was thought initially to have granulomatous uveitis. She had a fine needle aspiration biopsy in Hawaii and eventually a nucleation. We saw the case in consultation. She had massive anterior segment involvement involving the ciliary body stroma, the anterior chamber, and the trabecular meshwork. This is interesting. This is the fine needle aspiration biopsy tract in her cornea, showing lots of residual viable cells in the tract, and that really emphasizes the importance of Dr. Mounier's cryo procedure for sticking needles in the eye. Again, he has shown that it is safe and effective if it's performed carefully. Here's another case, a 20-year-old woman from upstate Pennsylvania that found to have an abnormal looking eye, a pink mass in the periphery of the anterior chamber, dislocating the iris root. But the needle biopsy showed a small blue cell tumor with necrosis consistent with the retinoblastoma. So she was treated with intravenous chemotherapy quite successfully, but then was lost to follow-up. And again, she had a large retinoblastoma with massive uveal invasion. Here's the confirmatory histopathology. Histopathology, of course, discloses risk factors for metastasis. The classic risk factors, of course, include extraocular extension and orbital invasion, massive posterior uveal invasion, optic nerve invasion, retrolaminar onto the surgical margin, and anterior segment involvement. Here's a case, a very advanced group EI that was seen in the probably with advanced disease due to COVID, tumors filling the eye, extraocular extension, and massive choroidal invasion. Okay, histopathology identifies high-risk histopathologic features that are an indication for adjuvant chemotherapy. As you know, the COG ARET study 3321 was a prospective study involving more than 320 patients from the US and India. Indications for high-risk features that were indications for chemo in this study included retrolaminar optic nerve invasion and massive posterior uveal invasion. Again, example of massive posterior retrolaminar invasion. Again, if it's behind the lamina, it's outside the eye. This was an obviously massive case of massive uveal invasion. Again, what is massive? Well, the International Retinoblastoma Staging Working Group came up with a consensus definition I think you're familiar with. It's greater than 3 millimeters in maximum diameter or full thickness choroidal invasion. The COG study also found that 16% of their patients had retrolaminar optic nerve invasion and 12.5% of them had massive uveal invasion. I think that probably the most important thing from the COG study was this group of patients. They were patients who had the poorest prognosis, the poorest outcome, These are patients that had massive peripapillary choroidal invasion combined with 1.5 millimeters or greater of retrolaminar optic nerve invasion. There were 3 of these patients, and they all died despite having normal adjuvant chemotherapy. And this group of patients suggested that such patients might require much more intense chemotherapy. The Cobb study also found that pathologists that contribute in institutions, which are often university-affiliated children's hospitals, improperly processed or misinterpreted the histopathology in about 20% of cases. High-risk features were not identified in some cases and were misinterpreted as being present in others. These are some examples of PO segments that were submitted to for pathology review. None for invasion, and one of them actually had retrolaminar invasion on the deeper sections. Some pathologists misinterpreted sub-RPE detachments by tumor as choroidal invasion. It's not choroidal invasion. And artifactual contamination was also misinterpreted in some centers. This case from our lab in Wills that was in the study actually changed the ACOG protocol and the standard protocol for dissection of eyes with retinoblastoma. In the initial ACOG protocol, the PO segment, the PO slide was submitted. This is the PO slide from our case, no high-risk features. Patient didn't receive chemotherapy. Several months later, the patients developed metastatic disease. We pulled our wet tissue, submitted the clots, and found this massive, greater than 3 millimeter area of choroidal invasion in one of the clots that was not seen grossly. So based on this, the COG protocol was changed, and we now bread loaf and both of the clots and submit them in addition to the PO segment and the transverse section of optic nerve as shown in this cartoon from Hans Gross-Nicholas. You also need good technicians that know what they're doing, that know how to make good sections that include the pathology that we want to look at. Another prognostic feature that's been reported recently is anaplasia. This is sort of a plus minus. It came out of the paper by P.M. Mendoza and Hans Gross-Nicholas's lab. And this is an example of a poorly differentiated anaplastic retinoblastoma, large pleomorphic nuclei with angular rhomboidal or fusiform nuclei with cell wrapping and lots of mitotic activity. Unfortunately, this anaplasia did not reach statistical significance in this study for death or metastasis, but it's thought to be still important. Histopathology rarely can provide clues to tumor genetics, particularly patients with RB1++ retinoblastomas. Again, generally accepted that both the loss of both copies of the RB1 gene is responsible for initiating most cases of retinoblastoma. These are RB1 minus retinoblastomas, but about 2% of patients with unilateral tumors and negative family histories don't have RB1 mutations that are detected, and these are called RB1++ retinoblastomas. As you know, this is 2.7% incidence in over 1,000 cases. RB1++ retinoblastomas are poorly differentiated. They tend to behave aggressively. They're diagnosed at a very early age. They're always unilateral, they're sporadic, and the siblings are not at risk. They also have unusual cytologic appearance. They are undifferentiated cells with large, prominent round or oval nuclei with multiple nucleoli, apoptosis. They don't have much calcification. And interestingly, they don't have Flexner-Wintersteiner rosettes, which typically are found in eyes from young children. Here again shows the round and oval nuclei in the case we saw a few years ago with the nucleoli. And we compare a minus with a plus tumor in these. Again, these are probably driven by amplification of the MYCN gene that shows multiple copies amplified in a fish. And of course, the tumor cell nuclei are immunoreactive for RB1 protein, shown in the immunohistochemical stain on the right. Relatively recent case, a 26-year-old girl who had recurrence after IAC. It's the enucleated globe. When I was doing the histopathology, I noted this group of nuclei, the round with nucleoli, was suspicious that this might be an RB++ case. We got the clinical record and found that the blood test actually had been negative for an RB1 mutation. We stained the tumor with an immuno for RB1, and indeed it shows immunoreactivity for RB1, suggesting that it indeed is that category of tumor. Okay, we currently have less histopathology to review due to eye-sparing therapies. I recently reviewed 35 eyes enucleated from patients with RB that were accessioned by our lab between July 2018 and 2021. Interestingly, 71.4% of these eyes had been treated previously. I hate to be sarcastic, but I tend to call these million-dollar eyes, you know, where you spend $1 million and then take the eye out, but I hate to be so cynical, but again, 14 of the previously treated eyes contain no viable intraocular tumor. Again, previously treated eyes may have had high-risk features prior to therapy that are no longer detectable. So we'll just have to worry about that. And again, we in the past did a evaluation of 297 enucleated eyes with untreated retinoblastomas, and we found the incidence in Philadelphia of high-risk features was 18.5%. I'd like to congratulate Dr. Munier for his absolutely gorgeous clinical pathological correlations in his excellent talk. So thank you for your attention.
Thank you very much, Ralph. Kaustubh, you're on for discussion.
Yeah. Thank you, Dr. Eagle. As you rightly pointed out, thanks to advances in treatment, we barely receive enucleations these days. And like you said, most of them are secondary enucleations. I have 3 questions for you. Now I'm going to put forward, the first one is about the number of sections from the central or peripheral calyx that we should ask a technician to cut before reporting. So there are 3 scenarios. The first scenario is that the tumor is confined to the retina. There is no local invasion. So before signing off a report, how many sections would you want to study before confirming that there are no high-risk factors? The second scenario is there is minimal choroidal invasion or invasion of only the optic nerve head or lamina cribrosa. Again, how many sections would you study before saying that there are no high-risk factors? And the third scenario is there is scleral invasion, which is limited to the inner 1/3. Now, before saying there is no extraocular spread or no full thickness scleral invasion, what is the number of sections that you would want to study?
Essentially, our technique, standard technique, is we'll do 10 H&E sections and 2 PASs from the PO block. Sometimes, if there's more tumor, I will do a second non-PO AP segment with 10 plus 2. Then we bread loaf our culottes. Maybe make maybe 4 bread loaf sections and do 2 and 1 in those. That's our standard technique. If I'm worried about it, I will send back. I will get additional sections if I am worried about that.
Okay. Now the second question, which there was a case, there was a situation where you mentioned that about 14 eyes which were previously treated did not have any viable tumor. So my question is about the same situation. Now, if in an enucleation, a pathologist sees only amorphous calcific deposits and necrosis, how would you report it?
Well,
How would you sign off the report?
No viable tumor. If I don't see any viable tumor, I'm going to, but I'll mention that there is a treatment regression scar consistent with prior therapy. Again, one thing I didn't show is that, 75% of the previously treated eyes did have obvious treatment regression scars. Sometimes you'll see a little bit of retinocytoma-like tissue at the margin of the regression scar, florets. There's another variant of retinocytoma where you don't have to have florets. But
okay, thank you, Dr. Eagle. And the last question, this is about the paper by Dr. Mendoza and Dr. Grosniklaus about anaplasia. How important is it to report on anaplasia in secondary enucleations?
In secondary enucleations, I have a problem with primary enucleations sometimes. I have the case I showed you. Was a slam dunk, horrendously anaplastic tumor. But the problem is that it's so. It's difficult. One criticism of of that paper, I didn't think that their photograph examples in their paper were particularly good. Again, I will comment if there's obvious anaplasia. I have not had the separated with the pre and post treated cases. It's just, if it's there, I'll comment on it. The question is, how important is it?
Okay, thank you, Dr. Eagle.